Hello, dear respected students. Today's our lecture is pericardial injury syndrome. You know, pericardium has two layers, visceral and parietal layers. Between them, we have pericardial cavity. Normally, the pericardial cavity contains about 15 to 80 milliliters of liquid. Pericardial injury is mainly secondary, mostly as a complication of other diseases. On the first place of etiology factors of pericardial damaging is infectious, like viruses, bacteria, fungi, and parasites. Systemic autoimmune diseases mostly can result in damaging of pericardium, like systemic lupus erythematosus, rheumatoid arthritis, ankylosing spondylitis, systemic sclerosis, dermatomyositis. Also, autoimmune processes type 2 may result in damaging of pericardium, like rheumatic fever or post-infarction pericarditis or Dressler syndrome. Pericardium may damage because of diseases of adjacent organs like acute myocardial infarction, myocarditis, aortic aneurysm, lung infarction, and pneumonias. Metabolic disorders also may have pericardial damaging, renal failure, myxedema, Addison disease, and etc. And also we are recognizing traumatic pericarditis, direct or indirect damaging of pericardium, and pericardial may damage because of primary or secondary tumors. And when you couldn't find etiological factors of pericardium damaging, this is we call as idiopathic pericarditis. There are some reasons of accumulation of transudate or non-inflammatory fluid in pericardial cavity, which called the hydropericardium. On the first place, heart failure, and also fluid can accumulate because of hypoproteinemia, because of decreasing oncotic pressure, for example, in liver cirrhosis or nephrotic syndrome, and some disorders which has pronounced violation of vascular permeability also may result in pericardial accumulation of fluid. Age etiology for children, character infective infections etiology. For middle age, mostly character bacterial reactive Dressler syndrome. Etiological factors for elderly, pericardial damaging mostly caused by tumor. And as a plural damaging, pericardial damaging has types: dry and accumulation of fluid or effusion, pericardial effusion. Let's start from dry lesion. Dry lesion or dry pericarditis has a symptom like pleura. The most important local sign is pain. Pain is constant, prolonged, and monotone nature of pain. Pain has connection with the position of body. Pain increase in supine position and weakened in upright position. Has connection with breathing and coughing. Increase with deep breath and cough. And nitroglycerin does not relieve pain, whereas nitroglycerin can help to patient who has angina pectoris, but who has pericardium damaging, dry pericarditis, nitroglycerin does not help. For character forced position of body, deep bow, sometimes lying on right side with knees pulled up to the chest. And for dry pericarditis, character inflammatory syndrome like weakness, sweating, decrease or lack of appetite, fever, leukocytosis with neutrophilic shift to the left, increasing ESR and acute phase proteins. Palpation and percussion for detection of dry pericarditis is not informative. That's why we are using auscultation, and auscultation has very specific symptom as pericardial friction rub. Is usually heard, it's usually local in nature, it's not carried out through the blood flow. And pericardial friction rub has particularities like hurt only on the zone of absolute dullness of the heart and it's not conducted anywhere, is high pitch and stretching sound. The noise is unstable and can change during the day in same patient, and pericardial friction rub increases in an upright and forward tilt position of the patient at maximum exhalation and also when pressing a stethoscope on the chest wall. ECG gives you concordant ST segment elevation extending to all standard leads within 2 days. Usually after 1 to 2 days, the ST interval falls below the isoelectric line, becomes convex upward, then returns to the isoelectric line within a few days. You see, there is differences between the acute pericarditis and myocardial infarction. In acute pericarditis, we have concordant ST segment elevation. What does it mean, concordant? When you have you see ST segment elevation in all leads, whereas for myocardial infarction, character reciprocal or discordant elevation of ST segment. When in one lead we have elevation of ST segment, and in opposite leads, for example, opposite to third lead is first lead, we have depression of ST segment. We have here elevation, and V5, V6 we have elevation and also depression of ST segment in V1 and V2. You see in pericarditis, for pericarditis character concordant or increasing elevation of ST segment in all leads. Next, it says accumulation of fluid in pericardial cavity or pericardial effusion. The clinic is determined by amount of exudate, its nature, and speed of accumulation of exudate. Exudate initially accumulates in the so-called physiological pockets at the place of attachment of heart to the large vessels, then in the lower part and at the diaphragm between the heart and the spine. Later, exudate appears at the apex and above the interior surface of heart. By palpation, you could find weakening of apical impulse. Sometimes it may not be detected at all. In case of massive fluid, enlargement of heart borders by percussion found, mismatching of left border of the relative cardiac dullness at the apical and the apical impulse. You see, if you percute and trying to find cardiac dullness by percussion will be in one place, but by palpation you find apical impulse on another place inside the from dullness. By auscultation, muffled heart sound will be diminishing of first and second sound, and in some patients with a large amount of exudate, a short but sometimes quite rough systolic murmur can be heard due to the prolapse of mitral valve that occurs in this patient. This murmur, like the prolapse itself, disappears after removal or reabsorption of the exudate. Venous pressure increase, and during examination you could find extracyanosis, swelling of veins, especially the cervical, swelling of face, neck, mainly in the horizontal position of the patient. The superior vena cava is more compressed. Liver increase in size and becomes painful because of stretching of liver capsule, and ascites, persistent dyspeptic symptoms may appear. Also may appear symptoms of compression of adjacent organs. For example, compression of lungs may gives dullness below the angle of the scapula, and on that side, on those region, bronchial breathing. Compression of esophagus gives dysphagia. Compression of phrenic nerves may appear by nausea and vomiting, and compression of recurrent nerves may appear by hoarseness. Cardiac tamponade, this is different one of type of exudative pericarditis, a life-threatening condition that develops as a result of sharp increase in intrapericardial pressure due to the accumulation of exudate, blood or pus, and leading to compression of heart and sharp decrease in diastolic filling of ventricles. For cardiac tamponade character, sharp increasing in intrapericardial cavity and sharp decreasing in diastolic filling of ventricles. On this picture, you see schematic imaging of exudative pericarditis without tamponade and with tamponade, and you see pericardial pressure in cardiac tamponade sharply increase, which caused the sharply suppressing of the heart and decreasing of filling, diastolic filling, and decrease the cardiac output. Most important hemodynamic consequences of cardiac tamponade are decrease of diastolic filling of right heart, stagnation of blood in veins of systemic circulation, hypovolemia of pulmonary circulation, decrease in left ventricular preload and decrease in stroke volume, violation of perfusion of peripheral organs and tissues. For cardiac tamponade, occurrence of stagnation of blood in pulmonary circulation is not character. Pulsus paradoxus or pulse of Kussmaul also character a sharp decrease in pulse filling at the height of deep maximum inspiration. In severe cases, pulse during inspiration may disappear completely. At the same time, systolic blood pressure decreases, usually by more than 10 mm Hg. Mechanism of occurrence of paradoxical pulse in patients with cardiac tamponade. During inhalation, increase of blood flow to the right heart cause displacement of intraventricular septum towards the left ventricle and reduce volume of left ventricle. That's why decrease cardiac output. During exhalation, we have displacement of intraventricular septum to the right side and increase size of left ventricle, and cardiac output become to be more. That's why we have differences of pulse during deep inhalation and deep exhalation. ECG signs are not specific. Total decrease voltage of ECG complexes may be character, and signs of atrial overload, various type of arrhythmias. For example, here you see low voltage ECG. What does it mean, low voltage? We have decrease R wave in standard leads less than 5 mm, in precordial leads less than 7 mm. Signs you see as the exudate dissolves, the voltage may of course increase. Also for cardiac tamponade character, full electrical alternation because of accumulation of fluid in pericardial cavity, heart in cardiac tamponade, heart in one time during contraction will be closer to electrode and apart from electrode, and we have electrical alternation. In one time we have low voltage, and another time which is shifted to the big R wave. X-ray picture informative feature liquid volume at least 250 milliliters in the presence of exudate, increase in boundaries in total. Heart shape has trapezoidal size, trapezoidal shape, the presence of an obtuse angle between the diaphragm and the shadow of heart. With a rapid accumulation of exudate, shadow of the heart has a spherical shape, for example in tamponade. X-ray, you see X-ray enlargement of heart in total, and also we have a losing of arch of heart. Here also you see X-ray of trapezoidal shape of heart during effusion of pericardium. Echocardiography, this is also gold standard. Following gradation of the severity of effusion used small, we have a divergence, you see here a divergence of the pericardial leaves in diastole less than 10 mm, moderate 10 to 20 mm, and large more than 20 mm, very large more than 20 mm in combination with cardiac compression, and small amount of liquid up to 100 to 150 milliliters, and moderate 150 to 500 milliliters, and large more than 500 milliliters. For example, 10 millimeters of divergence of pericardial leaves may formated during accumulation of fluid 150 to 400 milliliters, and if you have 3 to 4 centimeters displacement, it means about 500 to 1.5 liters of liquid accumulation. And there are complications of pericarditis. We have very severe complications as adhesive pericarditis, constrictive pericarditis, and armored heart. Adhesive pericarditis is characterized by the presence of pronounced connective tissue adhesions between the pericardial layers, sometimes formed during the resorption of exudate, the proliferation of granulation tissue, which is then replaced by connective tissue fibers. Constrictive pericarditis or compressive pericarditis characterized not only by the presence of adhesions between the pericardial layers, but also by the complete or partial obliteration of the pericardial cavity, which leads to pronounced compression of the heart. And armored heart, it's a variant of compressive pericarditis in which the pericardium calcifies and becomes a rigid, dense, inactive sacs around the heart. During constrictive pericarditis, we have 4 periods distinguished: latent initial clinical manifestation, then severe clinical manifestation, and dystrophic or terminal. During latent period, no complaints are present. Lab tests may be in normal condition. X-ray, echocardiography, and other instrumental methods not very informative. Initial clinical manifestation: by this time, adhesions disrupt the movement of myocardium in the diastole phase and make it difficult to completely relax the myocardium, and cervical veins are compressed. And in initial stage, we have cervical veins begin to swell and venous pressure increase. In severe clinical manifestation, venous pressure increase, sometimes up to 200 to 300 millimeters of water column. Ascites appear early and may appear hepatorenal syndrome, cyanosis, and neck face swelling, shortness of breath progression, but not orthopnea position. Heart rate increase and pulse may be weak, but there is still no edema on the lower limbs, whereas in dystrophic or terminal stage, characterized by severe changes in liver function and dystrophic changes in other internal organs, edema spreads to the entire body, face, arms, legs, and genitals, and edema is resistant even to the usual conventional diuretic treatment. Pericarditis of tuberculosis etiology is characterized by a great tendency to develop adhesion, with the subsequent outcome in constrictive pericarditis and then in an armored heart. Pericardial puncture techniques. Pericardial puncture is very important. First to treatment, next for diagnosis of pericardial fluid. There are several ways to puncture the pericardium. The most common and safe in Marfan techniques. Puncture is carried out in the position of patient lying on his back, and the heart head end of the bed raised by 30 degree, puncture under local provided under local anesthesia, and for puncture a long needle is often used. A conductor is connected to the needle with a clip connected to the electrode of chest electrode of the ECG, and this you see we connect this needle with the chest electrode of ECG, and by ECG you can control the contact with the pericardium. When in contact with pericardium, we have changing of these waves of ECG waves. If the ECG suddenly detect elevation of ST segment, this indicates contact of the needles with the myocardium. In this case, the needle should be pulled back into the pericardial cavity and elevation of ST segment disappear. Taken fluid will examined by transudate and exudate, and also should provide a cytological and bacteriological examination of fluid. If a connective tissue disease is suspected, the fluid is examined for the presence of antinuclear antibodies and LE cells. Okay, thank you for your attentions.